Okay, today we are going to talk about diabetes, and today's first lecture is just an introduction to diabetes. It is not detail of the diabetes. This is just an introduction to the diabetes mellitus, right? With little introduction to the diabetes mellitus as a overview. After that, we will shift to the fundamentals, right? We will talk about that how blood glucose level is regulated in a healthy person within normal limits, right? And blood glucose level and role of different hormones, hormonal interplay. There are hormones which prevent the hyperglycemia, and there are hormones which prevent the hypoglycemia in a normal person, right? So we will be talking about that too, right? So first of all, how do you define diabetes, right? Before we go that, I want to tell you that it's something very serious. You know, every 5 seconds, one person in the world is dying due to acute or chronic complications of diabetes. Again, it's worth repeating. It's such a serious disease that every 5 seconds, one person in the world is dying due to this disease. I always say that rather than saying that someone died of heart attack, sometimes we should write this man died due to, due to complications of diabetes, because many of the myocardial infarctions and or end stage renal disease or different type of strokes, right, they may be induced due to as a complication of diabetes mellitus, right? So actually we can say that so many people die due to complications of diabetes mellitus, right? Now, what is really diabetes? It is not one disease. It is not single disease. It's a group of many diseases, right? And all of them are lumped together in a bag. Again, I will say diabetes mellitus is not one single disease, right? It's a metabolic dearrangement in our body. This is a group of metabolic diseases, and this group of metabolic diseases are put together due to certain commonalities. Now, what are the commonalities? Common thread in all the diabetic patient is tendency for chronic hyperglycemia. What is that? Tendency for, chronic hyperglycemia, right? This is one thing. This is a common thread, right? Or we can say that this thread is, this thread, if this, I call this hyperglycemia, this is a death string, chronic hyperglycemia, right? Now, second thing which is important in this group of disorders is, number one, either there is reduced insulin production, or there is resistance to the action of insulin. Resistance to the action of insulin. So we can say that all those patients who are called suffering with diabetes mellitus, remember, whenever I say diabetes onward, I mean diabetes mellitus, because there is another condition which is called diabetes insipidus. That is entirely different disease. That is not characterized by hyperglycemia. Diabetes insipidus is a condition in which there is polyuria due to reduced production of antidiuretic hormone or reduced action of antidiuretic hormone. We will not be talking about diabetes insipidus. We will be talking about diabetes mellitus. And when I talk about diabetes mellitus, I will just mention onward diabetes. So whenever I said only diabetes, it means diabetes mellitus. What I said up to now, in diabetes mellitus, it's a group of diseases. Common thing in all of them is hyperglycemia. And in this hyperglycemia, what is there? Either there is reduced production of insulin or there is increased resistance to the action of insulin. Let me put it here. If this is pancreas and here are the beta cells and they produce insulin, right? And that is going through the blood to the cells and acting on its receptors, right? Now, either there is reduced production or there is reduced action, right? Or any combination of both things, that in some of the types of diabetes mellitus there is reduced production as well as there is increased resistance to the action of insulin. Is that right? Now we come back. Let's make it right. Let's make it diabetic monster, right? In this diabetic monster, right, we'll put it here. This is our death string. Here there is reduced production of insulin. And here what is there? Increased resistance to insulin, right? And in this death string, in this group of diseases, there are many different types of diabetes. For example, yes, the classical example in which there is reduced production of insulin is type 1 diabetes. That is type 1 diabetes mellitus, right? In this case, of course, we'll discuss type 1 diabetes in detail in future. But right now, what I'm saying, the type 1 diabetes mellitus is a classical example in which there is severe reduction in production of insulin. Why insulin is so less produced or sometimes absolutely absent? Because beta cells which produce the insulin, they have attacks by the immune system and destroyed. Or we can say that beta cells of pancreas are destroyed due to autoimmune reaction. This is one example. Then on the other extreme, we can put type 2 diabetes. In type 2 diabetes, the major problem is resistance to the action of insulin. At least in the initial stages of disease, what is happening, that beta cells of pancreas are there. They might be producing insulin in normal level or even more than normal, but cells are not responding to insulin, right? Cells become deaf to the insulin, right? So these are the two extreme cases, type 1 diabetes and type 2 diabetes. Classical thing in type 1 is there is absolute or very, very dangerous reduction in production of insulin due to autoimmune destruction of beta cells of pancreas, right? In type 2 diabetes, what we say classically in this case, what happens that there is insulin is being produced at least in the early phase of disease, right? Because this disease goes for many, many years or over decades, right? So at least in the beginning of the disease or early stages of the disease, insulin is being produced. The real problem is in the beginning that tissues are not responding to insulin. Is that right? So these are the only two conditions or two diseases. Then there are more diseases, type 1, type 2. After that, I can say, okay, someone said gestational diabetes. Okay, we put here gestational diabetes. Gestational diabetes mellitus or diabetes. What is this? This is a condition in which during the pregnancy there is tendency for hyperglycemia or there is hyperglycemia. Is that right? We'll discuss in detail later. But what happens in gestational diabetes? In this case, there is problem in production of insulin as well as there is peripheral resistance, that tissues are not responding well to the insulin. Then there is another condition with very interesting name. We call it LADA. Okay, who will tell me? LADA stands for what? Latent. Yes, L stands for latent autoimmune. Autoimmune. Yes. Diabetes of adults. Okay, let me tell you now interesting thing. If I talk about all the patients in the world who are suffering with diabetes mellitus, and if those patients are having real problem is underlying production of insulin, right? Most of them will be youngsters, type 1 diabetes. But if you find a man who is 40-year-old, right, a man 40-year-old or 50-year-old, and autoimmune process destroys his beta cell, which is less often, right? So actually at a very late age, he has developed autoimmune destruction of beta cell, so his condition will be somewhat similar to type 1 diabetes. So such patients are called not type 1 diabetes, because usually this is seen in younger patients, because this is very late onset of type 1 diabetes like disease. This is late onset of type 1 like disease, but very late onset, so we call it LADA, right? Basically both are similar condition, autoimmune destructions of beta cells. Then I would put, rather than putting gestational here, I will put gestational little down, and again I will put something which is very similar with type 2, right? Which is very similar with type 2, but develops at younger age. Again, type 1 classically develops in younger age. Type 2 classically develops in older age. Everyone knows that. Every good doctor knows type 1 diabetes is at younger age and type 2 is at usually later age. But if someone develop a disease like type 2 diabetes but at younger age, is that right? For example, someone has diabetes mellitus in the age of 20, but his real problem is not beta cell destruction, his real problem is increased resistance to the action of insulin, right? It means insulin is there but is unable to produce its action. Insulin is there but unable to produce its action. So that disease, but if it starts at very young age, classically it should start at older age. If it starts at younger age, we call it maturity onset diabetes mellitus, right? Or we just call it MODY. MODY stands for maturity onset diabetes of young people, right? Again, I will repeat and I will see who will tell me the right answer. First of all, we talk about the two extreme. This common string is hyperglycemia. Is that right? This is the death string and it has many death stones. It has many death stones. Death stones mean different types of diabetes, right? One extreme is type 1 diabetes, in which real problem is under severe reduction in production of insulin due to autoimmune destruction of beta cells. Other extreme is that there is problem with the action of insulin on the peripheral tissues, right? And at least initially insulin is present in the patient's blood. Gradually it might decrease. So this is type 2 diabetes. So classically, doctors, a good doctor usually knows about type 1 diabetes and type 2 diabetes. Then of course there are some doctors which are very good, right? If we talk about very good doctor, he will be aware of some slightly different situations. Very good doctor should be aware of that sometimes you might come across a patient who has diabetes mellitus. Sometimes as a doctor or as a nurse, you may come across a patient who has diabetes mellitus and it is at adult age, but this diabetes mellitus is behaving like type 1, like as if there is severe deficiency of insulin production. Real problem is, or at least initially, the real big problem is not peripheral resistance. So we'll call it LADA. What is that? Latent autoimmune diabetes of adults. Is that right? So another way we can say the real difference in type 1 and LADA is, one difference is that both of them are due to extreme deficiency of insulin, but one is at younger age and other is at adult age. Now we come to the other end. Every doctor knows about type 2 diabetes. Is that right? And every doctor knows that most of the type 2 diabetes patients are at older age, usually 35, 40 plus. But if you come across a very young person, right, and that person is having a type of diabetes mellitus which is behaving like type 2 diabetes, it means this person is having maturity onset diabetes, but in a young person. This person is having maturity onset diabetes, but in a young person, right? So we can say we have talked about 4 types of diabetes. Now we come to 5th type of diabetes we have already discussed, and that was gestational diabetes. Gestational diabetes mellitus or diabetes. Then gestational diabetes is easy to understand. Of course, all of you must be knowing this is only limited to the females. Okay, gestational diabetes. Then there is another type of diabetes which may be secondary to some situation, right? For example, if I take some drug and that drug produces hyperglycemia, and if I'm taking that drug chronically, if I'm taking that drug for a long time, right, then what will happen, that I will have a tendency for chronic hyperglycemia, and we say that there is drug-induced diabetes mellitus, right? So such kind of diabetes mellitus, right, they are called secondary diabetes mellitus. There are so many types of secondary diabetes mellitus, but just as an example, we talk about one drug. A very commonly used drug is beta blockers. Beta blockers, classically propranolol. Propranolol. Now, propranolol, it blocks basically beta receptors, right? And on the pancreas, in the islet of Langerhans, on the beta cells, there are beta 2 receptors, right? This is pancreas, here is your beta cell, and on the beta cell, there are, yes, this should be 7-pass receptor. This receptor is basically beta 2 adrenergic receptor. Is that right? Now, what happens that if we give beta blocker, this receptor is not functioning, right? There are alpha receptors there too. If these adrenergic receptors are not functional, right, insulin will not be released properly. There will be dysfunction in production and release of insulin, and person will develop a tendency for chronic hyperglycemia. So we will say this is an example of secondary diabetes mellitus. Another example we can take drug like thiazides. Patients who are for long term on the thiazides, it's diuretic, that can also produce picture like diabetes mellitus, right? Then we can talk about some endocrine disease like Cushing syndrome, where chronically there is elevation of cortisol hormone, right? And when cortisol hormone is high chronically in your body, yes, cortisol hormone and glucose metabolism. What cortisol is doing, or steroid hormones, right? What they are doing to your body. As far as metabolism is concerned, they produce catabolism of the proteins, they produce lipolysis, breakdown of the lipids. So, breakdown of adipose tissue and lipolysis produces free fatty acids, and amino acids are also broken down due to catabolism of the proteins, and both of them, free fatty acids and amino acid or their derivatives, they are supplied to the liver, and in the liver steroids increase the process of, yes, gluconeogenesis, and liver start producing glucose, right? So, what we can say in Cushing syndrome, there is a tendency, even in acromegaly and some other endocrine diseases, there is a tendency for hyperglycemia, and such hyperglycemia is called secondary hyperglycemia. So, what did we learn up to now? We just learned that diabetes is a dangerous disease, and every fifth second it is killing one person. Globally, about 500 million people are suffering from it. Globally, about 500 million people are suffering with the diabetes mellitus, and in USA they say there are about 36 or 37 million people suffering with diabetes mellitus. So when we talk about diabetes, it puts a lot of global load. There's a lot of morbidity, there's a lot of mortality related with it. I would say diabetes is a monster. Every year, how many people die due to this disease? Who will tell me? About 60 to 7 million people. 60 to 7 million people die of diabetes. So I must say that this is basically diabetic monster. And this diabetic monster with a death string of hyperglycemia having death stones in it. These death stones are different types of diabetes with two fundamental underlying process. Either diabetes is not being produced, or insulin is not being produced, or insulin is unable to produce the effect on the tissues, or both problems might occur, right? And type 1 diabetes, insulin is not being produced. And type 2 diabetes, what is the real thing? Insulin, at least at the initial stages, initial years of the disease, insulin is being produced, but tissues are not responding to insulin, right? Then we talked about other types of diabetes, right? Now, how diabetes kills? How diabetes kills? Due to its dangerous complications, right? As I told you, our first lecture is not diabetes in detail. I will talk in detail later, but let's talk about this monster and this monster's complications. Okay. First of all, we should know this is very dangerous. This diabetic monster, if unfortunately, let's suppose we imagine a person who has diabetes for a long time. He has diabetes for long time. There's not only chronic hyperglycemia, because a simple doctor, an innocent doctor, thinks diabetes disturbs carbohydrate metabolism, right? But the real doctor knows that even though main problem is hyperglycemia, but actually secondary to the insulin failure, not only hyperglycemia occur, not only carbohydrate metabolism is disturbed, but protein and lipid metabolism is also disturbed severely. So what we can say in this monster, okay, this I don't know how to make it look very angry, but in this monster, a simple and innocent doctor will think that carbohydrate metabolism is disturbed. But actually, yes, what is there? Lipid metabolism is also disturbed and protein metabolism is also disturbed. Of course, we will discuss all these disturbances in the metabolism later, right? In later lectures. But up to now, what is diabetes? It's a group of diseases, metabolic diseases. The common thing is hyperglycemia due to decreased production or decreased action of insulin or any combination of this, and eventually it disturbs not only carbohydrate metabolism but protein metabolism and lipid metabolism also, and I will definitely explain these things later. But because it is just fundamentals of diabetes, let's talk about what are the real problems with the patient, right? Number one, diabetes can produce vascular problems. Some people think it should be considered a disease, vascular disease with many other complications, right? So when we talk about that diabetes damages the vessels, right? The vascular disease or angiopathy which occurs in the diabetic patient, we divide them into two types: big vessel disease and small vessel disease. Why we say big vessel disease as a separate group, small vessel disease as a separate group? Why we differentiate? Because underlying mechanisms are different. Diabetes produces big vessel disease, which is called macrovascular complications, macroangiopathy, or macrovascular complications, or we can say big vessel diseases in diabetes mellitus. And then it also produces small vessel disease, right? And that is called microvascular complications or diseases. Complications or diseases. Now, microvascular means smaller vessels. Classically speaking, capillaries, but actually, true definition of microvasculature is, it starts from the arterioles, it includes the capillaries and then venules. But diabetes mellitus specifically and classically damages the capillaries a lot, right? So there are some complications in diabetic patient due to damage to the small vessels, and there are other complications which are due to damage to the big vessels, large vessels. Large vessels mean elastic vessels. Elastic vessel classically your aorta or muscular arteries, right? So bigger vessels, large vessels or mid-size vessels. Now, what are the complications it produces? Number one is coronary artery disease. Coronary artery disease, right? Let's suppose if I talk about atherosclerosis in coronary artery disease, right? Now, what really happens? You must be knowing that this macrovascular disease is not specific and limited to diabetes mellitus. It does occur with aging, it does occur with hypertension, it does occur in the patient with hyperlipidemias, and of course, it can occur in patient with diabetes mellitus, or there are unfortunate patients who have multiple factors, a patient who has diabetes mellitus, a patient who has hypertension, patient who has unfortunately hyperlipidemias too, right? So he will develop coronary artery disease. Is that right? But if you have diabetes, coronary artery disease behaves very aggressively as compared to other causes of coronary artery disease. Let's suppose there's a person who has hypertension and here's a person who has diabetes mellitus, severe uncontrolled diabetes mellitus. Patient with hypertension only and patient with diabetes only, both of them will develop the atherosclerotic disease or multiple atheromas, right? But in patient with diabetes mellitus, atheromas will be more severe, more diffusely present, and at earlier age developing. For example, if someone has uncontrolled hypertension only, he might develop, once he develops the hypertensive condition, he might develop, let's suppose, he takes 10 years to develop dangerous atheromas. But if someone has diabetes mellitus, within 5, 6 years, 7 years, he will develop very dangerous atheromas. So what I'm trying to say, that atherosclerotic disease or atheromas in patients with diabetes, they are more bigger, they are more diffusely present in the vessels, and they appear earlier. Is that right? So we can say that macrovascular disease, when it appears as a manifestation of coronary artery disease, in the presence of diabetes, disease is accelerated behavior and more severe behavior and dangerous behavior, right? Coronary artery disease, of course, it means in the patients with diabetes, if I say coronary artery disease is more common, what I really mean by this? Of course, they have stable angina, more common. They have unstable angina, more common. They might suffer with myocardial infarction, more commonly. They might suffer from sudden cardiac death, more commonly, right? I always think that someone who has diabetes and dies of the myocardial infarction, I think on the gravestone it should be written, this gentleman died of the complications of diabetes. Not just MI, just to increase the awareness, right? So what I said, that in coronary artery disease is one of the manifestation of microvascular complications, and they develop in the patient very commonly, right? I always say, we'll go to the other complication. Let's talk about another macrovascular complication, that is cerebrovascular complication. Cerebrovascular complications. Cerebrovascular events or cerebrovascular accidents. What I mean by this, that in patient with diabetes mellitus, large vessels or medium-sized vessels, either they are related with the heart or with the central nervous system, they develop what kind of disease? Atherosclerosis. They develop macroangiopathy. What is diabetic macroangiopathy? Number one, diabetic microangiopathy, macroangiopathy is not limited to diabetes only. This can occur in patients with hypertension, in patients with hyperlipidemia, or with advanced aging. But once it occurs with diabetes, it occurs very rapidly, very severely, and it is more aggressive. So, cerebrovascular accidents, CVAs, related with diabetes, they are very common. And again, CVAs can be stenotic, that reduced blood flow to some part of the central nervous system due to narrowing of the vessel because there is an atheroma and that if that atheroma is stable, but that has made the vessel narrow, we can say there is stenotic cerebrovascular disease, or there can be thrombotic, that at the top of atheroma, collection of, you can say, platelets and fibrin, right? They make a mass and make the vessel very narrow, may occlude the vessel and produce severe ischemia to some part of the central nervous system, right? So in that case, we say that patient has developed thrombotic CVA. Of course, in patient with diabetes, this is more common. Then we can come to embolic events. Embolic events mean that maybe thrombus formed in the heart, in the left ventricle, and piece of a thrombus break down and it moves through blood vessels and goes to central nervous system and block a vessel there. So this is actually embolus. Or patient has in carotid vessels, patient has very severe atheroma, at the top of carotid atheroma, platelets and fibrin aggregates occur, and we can say a thrombus form here, and that thrombus detaches from carotid vessel and goes upward to the cerebral circulation, and let's suppose it blocks the middle cerebral artery. Of course, it will produce a very severe CVA, cerebrovascular accident, and that will be considered embolic. Again, I will repeat, if due to diabetes, a vessel in the central nervous system become narrow, right, we'll say there is, and that lead to severe damage to central nervous system, that is stenotic CVA. Or there is the atheroma in the central nervous system, and over the atheroma, platelet plug or thrombus form locally, and this thrombus grows and closes the vessel. We will call this condition thrombotic CVA. Or maybe carotid artery, or from left ventricle, or from any other major artery, some thrombus flows to the central nervous system, right? That thrombus which has detached from its origin, and it is moving. If it is moving, it is no more thrombus, it is embolus. And if that damages your central nervous system, we say that there is embolic CVA. Now, in patients with and then there can be, of course, we should not forget hemorrhagic CVA. There can be hemorrhagic CVA also. In hemorrhagic CVA, of course, there is some vessels in the central nervous system, and in that vessel, very severe form of atheroma develop, and that atheroma damages not only intima but also damages the media and serosa so much that vessel ruptures. If that vessel rupture, right, larger size vessel, that might produce hemorrhagic CVA, right? So in patient with diabetes, again we come back, there can be microvascular diseases, there can be macrovascular diseases. When we talk about macrovascular diseases, what happens? We should really focus on coronary artery disease, which might clinically manifest as stable angina or unstable angina, or myocardial infarction, or sudden cardiac death. Then we should talk about other very important organ, central nervous system. If one of the major vessels in the central nervous system undergoes malfunction, if local thrombus is formed and making the vessel very narrow, we say stenotic CVA. If local vessel is having atheroma, we can call it dangerous, unstable, malignant atheroma, very dangerous atheroma, and this is so dangerous that it is not only destroying the intima, it is destroying the media and also serosa, right? And at the top of that thrombus, atheroma, if platelets and fibrin and thrombus form, then what we will say there is thrombotic. And if that a thromba ruptures, right, then hemorrhagic. Or if a thromba is somewhere else, right, and thrombus form over that, for example in carotid, and then a thrombus detaches and becomes embolus, and this embolus is moving in the central nervous system and eventually it blocks one of the major vessels, we call it embolic. And if someone asks you what kind of CVA is most common in patient with diabetes mellitus, you must say ischemic CVA. What you should say? Ischemic CVA, which is classically either thrombotic or embolic. Right? Thromboembolic or thrombotic or embolic problem. Is that right? Thromboembolic disease in the central nervous system producing CVA. So diabetes has so many ways to kill you. It can kill you by producing heart attack, myocardial infarction. It can damage you by producing what? Yes, what is this? Producing CVAs. Then it can, okay, can you tell me some more large vessel disease? Yes, doctor? Peripheral vessel disease. Peripheral vessel disease we should not forget, especially in the lower limb, especially in the foot, in the femoral arteries or popliteal arteries or even more distal arteries, right? In patients with diabetes, very aggressive and very unstable and in big number athromas develop as compared to the normal population, right? And those athromas contribute to the diabetic foot disease because due to those athromas or athromas with overlying thrombus, right, or embolus that may lead to ischemia to the foot, right? We call it foot vasculopathy in diabetic patient. So peripheral vascular disease can be there, right? And classical example is that blood flow in the lower limb in the patient with diabetes may be reduced due to complications of macrovascular, yes, macrovascular disease in lower limb vessels. This peripheral can develop in upper limb, but less often. But one thing I should not forget, large vessel disease, I've told you about coronary, I've told you about cerebrovascular diseases, I've told you about lower limb, but one special type of macrovascular disease or complication which develops in patient with diabetes is not to be forgotten. You know what is that? That is related with the kidney. Most of the doctors remember that kidney disease, kidney diabetic disease is microangiopathy. Yes, I agree to that. But major vessel which supplies the kidney, renal vessel, that can develop athromas, multiple athromas, dangerous athromas, unstable athromas, athromas with thrombi, which may even have emboli. So we call it, yes, that macrovascular disease or in the renal vessel, or we simply call it diabetic renovascular disease, right? Again, in a very short way I can say that diabetes can have so many complications. I was just focusing on some of the macrovascular complications, and we talked about that all of them are due to accelerated and more severe atherosclerosis in major vessels, important vessels like coronary vessels or cerebral vessels, or especially in the foot or renal vessel, right? Then we come to other group of complications, right? And this is microvascular complications in patients with diabetes. Small vessel disease. Up to now I told you only large vessel disease. Now I am going to tell you small vessel disease. Now here I want to say something very special. The small vessel disease, which is also called the diabetic microangiopathy. What is it called? Diabetic microangiopathy. This diabetic microangiopathy is specific to diabetes. What I mean by specific to diabetes, that it only occurs in patients with diabetes mellitus. Again, I will repeat. When I said that there is macrovascular disease that can develop in diabetes, but macrovascular disease can also develop in non-diabetic patients. But when I say microvascular disease, a very special type of microvascular disease which specially involves the capillaries, that capillaries basement membranes become very thick. Capillaries basement membrane become very thick because their proteins are altered, because there is non-enzymatic attachment of glucose or glucose products with those basement membranes, and those membranes proteins are altered. Even though microvascular capillaries basement membrane become thick, but they also become more leaky. They are thick but with cracks. They are thick basement membranes of the capillaries but having a lot of cracks. Due to that reason, they are very, very leaky, right? From blood, plasma proteins leak out through those basement membranes, right? So don't think that if basement membrane is becoming thick, it is actually becoming strong. It is becoming thick, but because it is thick due to pathological alteration in its proteins, collectively we call such altered proteins ages. What is it? Advanced glycation and products. Advanced glycation and product, that in the micro vessels, in small vessels, what really happens? Basement membrane become thick. Initially this process is reversible, but over the time it becomes irreversible because these abnormalities become very stable. Is that right? Now, classically and clinically, if we talk about diabetic microangiopathy, there are few organs which should come to your mind. Okay, let's start from the top. Number one is diabetic retinopathy. Remember, in patients with diabetes, some other complications can occur due to diabetes, like cataract, but that is not microangiopathy, right? That I will discuss later. What happens that microangiopathy develops in the blood vessels of retina, right? That retinal vessels develop thick basement membranes, and those basement membranes are not only thick, but they have a lot of micro cracks, and through those cracks, lipoproteins or lipids or proteins, they leak out into retinal neuronal tissue and damage it, even produce microhemorrhages, right? So, that can end up, I will say these complications, what did I tell here? One very dangerous situation, microangiopathy, yes, retinal, right? That is microangiopathy in the retina, we simply call it retinopathy. Which retinopathy? Diabetic retinopathy. Later on in lectures, in the future, I will tell you how to differentiate diabetic retinopathy from hypertensive retinopathy. This is very important as a doctor to know. You know, retinal vessels are the only vessels in the body which you can look directly in a healthy person. There are no other vessels you can look directly, right? So, when you do look at the retinal vessels, right, you can, in diabetic patient, you can find abnormalities there, right? I will teach you later. There will be a full lecture on diabetic retinopathy, but right now I am telling you there is two types of diabetic retinopathy. At early stage, it is not having proliferation of small vessels. It is not having neovascularization. But when diabetic retinopathy, it becomes advanced. What happens? That new vessels sprout, new vessels grow, right, in the retina. And don't be happy every new vessel is good. Everything new in life is not good. I have some experiences. Yes. So these new vessels which develop in the retina, even though the bunch of vessels, we call it, what we call it? Diabetic proliferative retinopathy. What we call it? Diabetic proliferative retinopathy, which occurs at advanced retinopathy. These newly formed proliferative vessels or neovasculature, this is super leaky. We don't want vessels to be super leaky, right? And when they leak there a lot, they leak a lot of inappropriate substances which should be limited to the blood, but unduly lot of proteins or lipids, they come into neuronal tissue of the retina and produce a lot of complications. We'll talk those things later, but right now you just remember that one of the most important cause of blindness is diabetic retinopathy. And now you are going to tell me without thinking, is it a macrovascular disease or microvascular disease? It is microvascular disease. It is microvascular disease, microangiopathy, right? Number one. Number two, after the eyes, another tissue which loves to have this angiopathy, that is nephropathy. Your kidneys. You know, in kidneys, you have millions of, about 1.2 million nephrons in each kidney. How many nephrons? 1.2 million. As I say in some lectures, that you are millionaire as long as glomeruli of the kidneys are concerned, right? About 1 million to 1.2 million nephrons you have in each kidney, right? And in every nephron there is a bunch of capillaries which are called glomeruli. Those glomerular capillaries, also loves to develop microangiopathy in diabetic patient. I think they love too much sweetness because their, what are this thing? Glomerulus. In the glomerulus there are glomerular capillaries, and capillaries are having some substance in between which is called mesangium. So this capillary, their basement membrane and their mesangium, all of them develop advanced glycation products, and that will lead to what thing? That will lead to damage to the glomeruli. And over the years, damage to the glomeruli become, what do you think? This will affect more right kidney or left kidney? Yes, doctor. Both kidneys, of course. It is hyperglycemia which is damaging. Of course, whatever hyperglycemia is occurring in vasculature of right kidney, same is on the left. So this microangiopathy which develops in the blood vessels of the kidney, classically in the glomeruli, even though they can develop in peritubular capillaries also, right? They produce dysfunctional, what is this? They produce dysfunctional glomeruli, and over the time, over the years, over the many years, if patient is not taken care properly, this angiopathy becomes so advanced that glomeruli stop functioning and person enters into end stage renal disease. And in USA, the most common cause of end stage renal disease is diabetes, diabetic nephropathy. So what I'm trying to say, that this disease has so many faces to kill you. It can kill you by myocardial infarction or sudden cardiac death or cerebrovascular accident, or it may kill you over many, many years. I say this disease loves to kill its patient. Inch by inch, this disease, this monster of diabetes loves to kill its patient in many different ways and over the many years and inch by inch. I told you there was death string of hyperglycemia with the death stones, different types, and this death monster has macrovascular complications and also having microvascular complications. And when we talk about the macrovascular complication, I know I am repeating, it's worth repeating that that patient may suffer with the heart problems or brain problems, central nervous system problems, or renovascular disease or foot vasculopathy, right, peripheral vascular disease. Then it can, if it does not kill, at least it can make you blind. That is also a very miserable situation, you know. There are so many beautiful things in life which you cannot see if you are blind, right? So it can produce blindness by diabetic retinopathy. That is example of microangiopathy. Then we talk about diabetic nephropathy. Now here, what is this? Macrovascular disease. But in glomeruli, it is microvascular disease. In glomeruli, it is microvascular disease. And again, I will repeat, one of the most important cause of end-stage renal disease, especially in the advanced country, that is diabetes mellitus. Because in poor country, unfortunately, many patients die due to pyelonephritis, right?